Welcome to Let's Talk. Today I have the privilege of hosting someone who has had a profound impact on my career, Professor Patricia Reesick. I first had the opportunity to learn from Patty in the early 2000s when she taught me not only how to treat PTSD, but also what true professional and academic generosity looks like, something that is far from guaranteed in our field. Over the years, she has mentored and shaped generations of leading professionals, many of whom have gone on to further the research and application of trauma treatment across healthcare systems and the military. Professor Riesig is the distinguished clinical psychologist, researcher, and educator whose contributions have transformed the field of trauma treatment. She is best known for developing cognitive processing therapy, CPT, one of the most effective evidence based treatments for PTSD. Her work has been implemented worldwide in clinical settings, healthcare institutions, and military organizations. Beyond her clinical contributions, Patty has held prestigious academic positions at institutions such as Duke University, the University of Missouri at St. Louis, and Boston University. She has also served as the director of Women's Health Sciences divisions at the National Center for PTSD, where she played a crucial role in advancing trauma research and treatment within the Department of Veterans Affairs. Her research has led to groundbreaking insights into how trauma impacts cognitions and emotional processing, shaping the way we approach and treat PTSD today. Her dedication to rigorous scientific inquiry, combined with her unwavering commitment to training and mentoring others, had a lasting global impact. Patty is also a prolific author, having written and co-authored numerous articles, book chapters, and books. Her books have shaped the way clinicians understand and treat PTSD. I want to mention two of her recent books, Cognitive Processing Therapy for PTSD, a comprehensive manual which serves as the definitive guide for clinicians learning and implementing CPT, and another book, Getting Unstuck from PTSD, Using Cognitive Processing Therapy to Guide Your Recovery, a self-help workbook designed to make CPT accessible to those seeking recovery from PTSD. One of Patty's most remarkable contributions is the community of professionals she has trained and inspired. Her trainees have not only become leading clinicians, researchers, and educators, but have also carried forward her ethos of generosity. They continue to expand the reach of CPT, training others, refining its implementation, and ensuring that effective trauma treatment is accessible across different populations and systems. This network of professionals have played a critical role in embedding and disseminating CPT within healthcare institutions, the military, and global trauma response efforts, making tangible difference in the lives of countless individuals. Since the events of October 7th, we in Israel have trained 550 mental health professionals, and today we are running dozens of supervision groups across the country. This work would not have been possible without Patty's groundbreaking contributions and the legacy of expertise she has fostered. In our conversation today, we'll explore the journey developing CPT, the science behind it, and the evolution of trauma treatment and the future of PTSD research and intervention. Okay, let's talk. I'm very happy to have you here, Patty. I want us to start by, talking about the early years, how you developed cognitive processing therapy.
I started working with rape victims back when nobody was studying trauma at all. Carrie Keene started studying veterans about the same time I started studying rape victims. And I was asked to be a rape crisis counselor while I was still a graduate student. And being a good little graduate student, I went to the literature to see what was there. And one of my classmates and I looked through all the issues that we didn't have computers. So we looked through all the issues of psychological abstracts, and there were only 4 articles on the topic of rape. One was about pastoral counseling. One was about the interruption of the psychoanalytic process by a rape. Like, how dare they? And then 2 of them were about victim precipitated rape, which means these were in criminology journals, and they were blaming the rape victims. That was it. That was the sum total of our knowledge of rape in the literature. So when you think about how far we've come,
You said victim blaming was the professional articles we had.
yes, that was where the profession was, and I literally had professional psychiatrists and psychologists say, "What's the big deal? Why, like, this isn't a field." My advisors even said, "This isn't a field of study. You'll never get tenure if you go to a university and study this." But while I was working at the Rape Crisis Center and doing my internship, and then I went back to finish my dissertation at the University of Georgia, the federal government funded $3 million, and the National Institute of Mental Health funded $3 million to study rape, and that was huge, in 1976 dollars. And
It sounds big even for today. It's
Yes,
just amount of money for study.
yeah, they funded several states, but I before I went back, while I was still in Charleston at the Medical University of South Carolina, I worked on a grant proposal with Dean Kilpatrick. And that was studying fear and anxiety and looking at them over time. And then I went back to Georgia, and Karen Calhoun asked me if I wanted to work on a grant application with her. We decided to study the depression symptoms following rape. And so those were longitudinal studies just to understand, like, the reactions that people had and how strong they were, how long they lasted, and that sort of thing. And yes, we did find both depression and anxiety were symptoms that lasted, and particularly with the about half of them still had. Edna Foa did a study around that same time. I think she was one in the first group where they got a grant to do longitudinal work, and she found out that at 1 week post rape, almost everyone met the criteria for PTSD, which had just come out in 1980, by 1 month, 75% had it. By 3 months, about 50% still had and did meet the criteria for PTSD. Obviously in the first weeks, it's not diagnosable, but then
Say it was that basic that we didn't even have the knowledge of how people respond to.
No. And we knew nothing. We knew absolutely nothing about crime, about the effects of crime on victims, homicide, rape, child sexual abuse, domestic violence. We knew nothing back when I first started. But we also, as part of that first study, we're trying to do a brief treatment, and it didn't work all that well. We didn't know what we were doing. And we didn't know who was going to recover naturally. And it turns out a fair number do recover naturally. So we really needed to do a randomized controlled trial to see who's going to recover and who isn't, and then why. I started doing research when I then moved to University of Missouri, St. Louis. And I tried a couple of things at first, and I did one small randomized controlled trial comparing stress inoculation training with kind of general counseling, and they both worked equally well and not tremendously well. They worked okay, but I wasn't satisfied with that. And I wasn't that happy with the exposure treatments, because I kept thinking the exposure treatments were really focused on fear. In fact, they still focus on, a lot of people still think of it as a fear disorder, even though it's not.
And it's amazing when you think about how many emotions people describe after trauma.
Exactly. And
No,
I-
I can say from the experience we have here now in Israel, we see a lot of people who are, they're grieving or disgusted from some of the experiences that they had.
Yes, horror, just sadness. Yeah, exactly. And because I had been working with rape victims, some of them would say to me, I didn't think that he was going to kill me. It wasn't it isn't the fear that haunts me. It's the fact that he betrayed me. It's the fact that I was so shamed by what he did. It was so disgusting to me. And so then I was thinking, this isn't just a fear disorder. It's much bigger than that. And of course, it took a long time to get it until the DSM-5 to get it moved out of the anxiety disorders. Get several DSMs, and I kept arguing it's not an anxiety disorder. They just didn't listen. But in the meantime, I had been looking at the work of Aaron Beck on working with depression with cognitive therapy, and I thought this is a broader spectrum treatment. This could treat all of the emotions that people are having and the thoughts that lead to those emotions. And so I started really focusing in on that and looking at the work of McCann and Perlman had written a book about trauma, and they focused a lot on the themes. They were more psychodynamic, and we're thinking longer term therapies, but I wanted to do something that was cognitive behavioral, but taking some of their concepts and taking the style of Beck and putting them together into a shorter therapy. And so the original CPT is about 12 sessions.
In the original CPT, so you combine the ideas of McCain and Perlman on the one hand and Beck on the other. And you created a protocol and you tested it on both groups, right? Or a group. And
I started with groups. Yeah, I started with groups because I could collect more data at the same time. I had 84 pilot cases before I got a randomized controlled trial funded. So I knew pretty well that CPT worked by the time I had it funded by the government, and that was to compare CPT with prolonged exposure, which EDNFOA had come out with, and so I used her as a control group, and then we had a wait list control group, and I did it twice a week for 6 weeks. And then the people who were on the wait list got randomized to one of those two conditions. And then I collected lots of data, not just fear and anxiety and PTSD, but, we had dozens and dozens of articles that came out looking at, emotional responses and social functioning and health and all sorts of things.
I want to ask you, I think one of the unique aspects of cognitive processing therapy is actually addressing both natural emotions and manufactured emotions. And, actually, I think for me, this was the first time I was exposed to this idea was through learning cognitive processing therapy. And I think it's very important, as a general principle of psychotherapy to address these two types of emotions. How did you come up with these?
Well, there's some emotions that you don't need to think about. I mean, if you're in danger, you're going to feel fear. So if I'm pushing you, you're standing on a tall building and I'm pushing on your back, you don't have to say, oh, I should feel fear now. And then if I turned around and said, just kidding, I don't think it would take much for you to feel anger. You wouldn't have to think about it. But if you blamed yourself for being there with me, then that would be a manufactured emotion. And I was hearing a lot of those things. It just didn't make sense. The natural emotions decrease over time because they're natural emotions. You feel them and they get less and less over a period of time. And not always as fast as we want, but they do decrease. But the manufactured ones, the ones that you've got a little factory in your head producing thoughts. It's my fault. I should have done this. I should have done that. You keep redoing the event and blaming yourself for it or blaming somebody else falsely who didn't intend the harm. The sergeant sent me down that road, so it's all the sergeant's fault. Well, they could have.
These are the things that we see now with soldiers. We see them either blaming themselves or, blaming their commanders, blaming the military.
As if the commander wanted to kill them. or that it hadn't been cleared earlier, or that they knew exactly. Sometimes they have magical thinking about how much the commanders know about what's going to happen in the next hour or two. So yeah, there is falsely blaming someone else or blaming yourself for something that you had absolutely no control over would be a manufactured. And you can keep your PTSD going for decades. When I moved to the VA in Boston, we were treating World War II veterans. We were treating Vietnam veterans with CPT. And you can keep it going for a lifetime if you keep saying those things that are going to lead to those other really negative emotions. So you gotta peel off that layer of negative emotions that are caused by not thinking about it in a helpful way, or not taking in all the facts of what actually happened or what they could have actually done, what options they had, and then get down to those natural emotions. So sometimes those people who you think should be having grief are feeling angry instead of feeling grief, or they're blaming themselves, or they're saying, it should have been me and not him. He has a wife and 2 kids. And it's like, okay, but the person who was shooting that rocket didn't know that. They weren't aiming for your friend. They were just shooting. So it's like, where does fair come into this? And we got into just world thinking and hindsight bias and some of those cognitive things that people tend to do. People love to have prediction and control. They want to think they could control events. And so when they don't have control over events, they sometimes twist them around to get the idea that they had control or they should have had control.
So, and this is, I mean, I agree. And this is what we see a lot of this, the people we treat from the military or from the Nova Party or the October Studded events. Another thing that we have to address very commonly is the grief that people experience over losses that they have, either friends from the military or people that they lost, close friends that they lost. And I want to hear a little bit from you. In my view, CPT addresses loss and grief, and I want to hear your understanding of how to address these issues within the treatment.
Well, I think we have to accept that loss and grief are natural emotions, but you can also get distortions on top of that when you feel guilty about your grief, or you think you're not doing it right. I mean, people always feel like they're not grieving right. They're doing it too much. They're doing it too little. They shouldn't be doing it. They're not honoring their friend if they get better and don't have their PTSD symptoms anymore. So if people have prolonged grief disorder, that comes from natural grief. There is a traumatic kind of grief when you also have PTSD that compounds with the grief response, and you don't actually get to the grief and the sadness because you're using those manufactured thoughts that are interfering with the natural flow of and it takes a while, sometimes longer than we wish, but getting back to the natural feeling sad as a natural emotion, instead of just feeling angry at themselves or other people, or blame or guilt or whatever it happens to be. So then we have to separate out whether they're actually just feeling grief, if they're feeling their sadness, and then I'd be encouraging them to feel their feelings.
I want to ask you, so in terms of the manufactured emotion, something that we use cognitive therapy skills, and the natural emotions we want the people to feel, and the focus of the therapy, my sense is that the focus of the therapy have changed over the course of the year. I can say I'm thinking about cognitive processing therapy 22 years ago or 23 years ago, and cognitive processing therapy today. My sense is that it's much more accurate, that in a way you pin down where we should focus.
Well, we definitely know that we need to focus on the trauma itself first. and any distortions or erroneous thinking they have about why the trauma happened. And so we definitely pin that down, because we want them to get to more balanced thinking, because that's going to lead to a different emotion. And when we hear the natural emotions, that's when we sit back and shut up. And I think sometimes people get too cognitive. A therapist error would be when they jump in with another question and not let them feel their natural emotions. But when you're hearing the erroneous stuff, that's where we have to really help them think about, okay, was that even an option? Could you have done something to save that person? How far away were you? What abilities did you have? What could you have done differently, and how did it actually happen? And accepting that loss of control over the event itself, and then accepting that it happened just the way it happened.
A lot of therapists ask me, this is something, they want to go and target the thoughts that are, it's very dangerous and at risk, and or target the emotions of fear, and not necessarily start with the memory. They want to start with the client's life. They avoid, or they. So, and I know this therapy, as it's built, it starts with the
trauma. It starts with the past,
right.
Because the thoughts they have currently that are overgeneralized, like everything is dangerous. I mean, I wouldn't target and say that it's possible that a bad thing could happen again. That's realistic. But if they're saying, I can't leave my house because it's too dangerous, bad things will always happen, then now can we take it down a step? Is it always, or is it sometimes? But that's for later in the therapy. Where did that thought come from? It came from the trauma. So we start with the trauma. You don't lose trust just naturally. It starts with the trauma. So we start with the trauma, then it's easier to work on those over-accommodated ones, the overgeneralized beliefs about dangerousness and fear and so forth. That's why it's in the second half of the therapy. And often those fall apart once you've dealt with the trauma itself. They don't believe it so much about everybody.
It's interesting. I'm listening to you saying it, and I'm thinking about a lot of the therapists that we are training now. And, they say, but he's not sleeping well, or he's not, his hyperarousal symptoms are so severe. I want to give him the, relaxation technique, and break the protocol.
That's a common beginner move. We see that a lot. Or somebody will stop and say, I've got to do EMDR in the middle of the protocol. The thing is that if they are having serious insomnia, maybe people like or don't like research, but there's been one study that looking at a treatment for insomnia, succession treatment, CBT-INN, and they looked at it before CPT, and they looked at it after CPT. And then they also look at CPT plus more CPT, and doing it CPT plus CBT-IN worked better. And they had much better results on their insomnia after. There's been at least one study or two that have looked at adding depression treatment after CPT. So you start with the CPT, and then if they still have some residual symptoms, then you add something. You don't stop in the middle.
So you're saying to those beginners, treat the trauma first. And then whatever left, address it in the treatment protocols that should address it.
Right. And it's so tempting to go, I call it low-hanging fruit. When somebody says, I can't trust anybody, your temptation is to go anybody and go like 2-year-olds, your grandmother, you want to argue about the term anybody, but that's later in the therapy. They're going to realize that, yeah, of course there's people they can trust in certain ways. But
in a way, that's why we have the stock point law, right? So we can have all these listed and get back to them as therapy progresses.
Yes. And really being able to pick out which ones do we focus on first. They're all about the ones that are all about the past are the ones we start with. And then halfway through therapy, when they get to the point where they can do the alternative thought log, then we start moving into, if they still have some stuck points about the trauma or other traumas, they can still work on those, but then we start introducing the themes, the hierarchical safety, trust, power and control, esteem, intimacy, and have them doing the full worksheets on those. And usually those go pretty quickly because you've already resolved the trauma.
And I can say some of the therapists that are currently doing the therapy are surprised when they see that the symptoms drop, almost only on the trauma.
Yeah.
Another thing that we see, and I think that people are confused about it, is the combination of PTSD and OCD. And, clients were saying, if I think about it, something bad will happen. And it's a thought action fusion or thought event fusion that they have that is related to the.
Yeah, it's about the trauma.
Right.
Yeah, I mean, there's a difference between somebody who had OCD prior to the trauma happening, and then their OCD gets worse. And it may not be entirely related. It's just that's their way to reduce anxiety. And people do their compulsions as a way to reduce their anxiety. But there are PTSD-related OCD symptoms, like if somebody is raped, they're going to feel dirty. And so they may wash and wash and wash and wash and wash. Or if they were attacked in some way, checking and making sure the doors are always locked. Or as you say, that linkage between if I do something bad will happen. And so I can't do those things. Or they get into magical thinking about doing superstitious behaviors. So that's where the worksheets can really come in helpful. And then what we find is we don't have to assign them to do those things. What we have to do is work through their thinking about it and think about times when nothing bad happened when they did X, Y, and Z, like leave the house. And like with rape victims, we can go through a whole, one of my colleagues in Germany looked up how long it takes you for all your skin cells to change over. And so she was able to say to the rape victims, there's not a single cell that rapist touched inside or outside of your body that he has touched now. It's been too long. Those are all new skin cells. He has not contaminated you. He's the one who's contaminated, not you.
Yeah, I think that's something that a lot of times, especially with rape victims, they're looking for something about them that they like happen, or
or they feel damaged, they feel dirty, they feel contaminated, any of those kinds of things, and that might lead them to doing those behaviors like washing repeatedly, or they always look to themselves. Well, most people with PTSD look to themselves first, because again, they want that sense of control. They want that sense, if I only did something differently that day, it wouldn't have happened. I could have prevented it, or it wouldn't have happened to me, or it wouldn't have happened to my friend if I just did X. And so that kind of rumination is almost like an avoidance symptom, like where they'll think about all the things they could have and should have and would have done differently if only they had control.
As you are talking, I'm thinking about the challenges we have in Israel currently.
Okay.
And, a lot of the people that turn to therapy, or maybe not a lot, some of the people that turn to therapy are families of those who've been abducted. And, I want to know if you have any thoughts about how to address this. They do have PTSD, some of them, they have that, many people were on the phone with family members that were kidnapped, or, they saw videos of family members being kidnapped or murdered, and they have PTSD, and, and yet some of them are dealing with not knowing and with the, I think the challenge of uncertainty that is surrounding their family or surrounding, and we as a nation, we have a lot of uncertainty about some of the people that are still in Gaza.
Yes. you're not going to use CPT on something that's a normal and not stuck point kind of thing. So the uncertainty is true. I mean, you can't change that. That uncertainty is there. But you want to hear what they're actually saying to themselves. Are they saying, I shouldn't have let her go to the festival? I should have known. I should have moved back to the United States before it happened. It's like if they're feeling guilt, that you can work on with the CPT. So I'd want to hear, what are they saying to themselves about the cause of the event? If they're accurate about it, you just say, yeah, that's what happened. And it's appropriate to feel sad. It's appropriate to feel anxious about not knowing. I mean, those are appropriate emotions. We're not going to take those away from them. If they're feeling guilty because their child was returned and somebody else's wasn't, that also is out of their control, isn't it? So why should they feel guilty? Or if somebody's angry because somebody else's child was returned and there wasn't, so again, out of their control. So I would be working on the thoughts that are unhelpful.
I want to ask you two more questions.
Okay.
One of them is if you have anything to say and address to people who are dealing with PTSD, and based on your years of this experience that you had with helping and changing and impacting the lives of others with PTSD.
I'd say the first and most important thing is don't avoid. And by avoidance, I mean trying not to feel your feelings, not to think about it, not to, doing unhealthy things to yourself or others. Trying to reduce your anxiety through unhealthy things would be like drinking or using drugs or doing self-harm behaviors of any kind to try to reduce your anxiety. But just feel your feelings is what I'd be saying, is like whatever you're feeling, and as long as it's not based on a unbalanced thought, is fine. Just talk to people, reach out, don't withdraw from other people. And I think that's where community is so important. And most people don't end up with PTSD in the end. And if you look at the big statistics, we end up with maybe 10% who have chronic PTSD. So a lot of people are going to recover when the war is over, if they just get it done.
I can say for us, I think it's sometimes surprising to see what people can go through.
Yes.
And recover.
Yes.
I usually say, you're not amazed when you had like a bad cut or injury and you heal. And it's the same amazing things happen to us psychologically when we go through trauma.
Well, I mean, think about Viktor Frankl, who wrote, invented logotherapy, which of course is a cognitive therapy, and came out of the Holocaust and being being in a concentration camp. I mean, talk about resilience. And he was an amazing person, but he also, I think, learned about how to think in a more balanced and healthy and in-depth way.
Another person who influenced the lives of many.
Yeah, he also influenced my thinking.
Looking back at your career,
Mm-hmm.
Did you ever imagine that you influence the lives of so many people?
No, no. I mean, I was working to try to find a therapy that would work, but I didn't know that so many people would benefit. And I love getting emails from therapists or from patients who said, I read the self-help book that you did and it really helped me. I wanted to thank you. And it's like, oh, that's lovely. That makes me feel very good.
Well, I can say from my own experience, I approached you and came to do the training, and it influenced my whole career in terms of and what we're doing now in terms of disseminating the therapy in Israel with the supervision. It's really impacting the lives of of many, clinicians and clients. So it's really.
That's great.
You mentioned the avoidance, and exposure therapy addresses avoidance directly,
Mhm.
and I want to have some of your thoughts on addressing, especially severe avoidance with people with PTSD.
You mean with using CPT? I got to get in the door first, either through telehealth or coming to the therapist, or the self-help book is also. I've been plugging that lately because people are finding that very helpful when they can't go to a therapist, they can't find one. That kind of thing has been trained. But yeah, you can't put the book back up on the shelf and forget about it for 3 months. You really got to work it. So just coming into therapy, just starting to talk about what happened to you is stopping the avoidance. And then that's why we have so many practice assignments, because the PTSD is out of the office, it's out where they live. And we want them thinking about different ways to deal with it every day, every day, every day. So the people who are going to do the best are the ones who are really going to do the most worksheets and really think it through and have flexible thinking, which is unfortunately something we don't tend to teach in military training. We teach follow the rules, rigid thinking. And when they get home, it's hard for them to change their minds because they're taught certain things that sometimes are literally stuck points. You're responsible for your men, not you're responsible to your men. So they'll take on guilt about things that happened to their men even when they weren't there. Or one of the ones I hate the most is if everybody does their jobs, everybody's going to come home. What a myth. That's a terrible thing to say to people who are ready.
Yeah.
I know they're trying to reassure them and get them to get out there, but it's just not going to happen. Stay alert, stay alive is going to encourage hypervigilance. There's all sorts of things that people will see and learn in their military training that they learn. They need to learn they can change their minds. They need to learn they can be flexible in their thinking, and they don't have to stick with what they thought to begin with.
So you're saying you can work through avoidances through cognitive work. You don't have to send the client to, practice again and again.
No.
Okay.
No, you can do it with the cognitive work. I mean, and you don't even have to get into the gory details because that's not what their PTSD is. Their PTSD is usually what happened right before that. And as I said, the prediction and control piece of it, where they're going back and trying to undo the event after the fact. It's not the seeing the gory sight that they're stuck on. It's like trying to prevent it afterwards. And so that's why we can use cognitive therapy around it. They don't need to go through all those gory details again and again and again. That's not where their PTSD is.
It's an interesting concept. We are currently studying, actually, training people. It's actually some kind of a functional dispute in terms of going over whatever, thinking that they have. And it's interesting to see, because once people see that it's not functional, they're actually able to say, I'm not going to get into the story. So in a way, it's something I think it's similar to what you're saying. I can have a choice over, do I go over this again and again, or do I just, allow myself to feel the feeling associated with it, but continue or.
Yeah. And just, that's what I'm saying is approach, don't avoid. Talk to people. Tell them how you're feeling. Tell them what your thoughts were. Anke Ellers and her group up in England were the ones who started looking at what's the content of flashbacks. And then usually the flashbacks tended to be the moment right before the trauma, not the trauma itself. And then with nightmares, that's when they wake themselves up, is after that moment. And so it's usually that I've got to stop this, or I could stop this, or I should stop this. So the problem is after an event is over, you can't stop it. So you get stuck there.
Okay, so I think my take home message is assimilation first.
Yep. Absolutely.
And don't avoid.
Yes. And don't avoid.
Okay.
Okay. And and therapists need to be curious and modest in their assumptions, because they can't make the assumption of where the PTSD is. They'll go for the gory parts and not the self-blame or whatever it is. And don't be argumentative with the client. You can't convince somebody. They have to figure it out for themselves. That's why we do Socratic questions, not argument.
Yeah.
Okay?
And that's an art.
That's it's an art and a skill, but yeah.
Yeah.
Fortunately, it can be taught. Some people are better at it than others. Well, and learn for themselves too. When I have done workshops and I've been teaching and people ask me questions and I'll ask them some questions, and they'll say, are you doing Socratic dialogue? And I say, yeah. And so I'm doing it with the therapists. I do that, I would do that during consultation. And just really listening to the clients and not making assumptions about sometimes the new therapists are so busy thinking about the next question they're going to ask that they forget to listen to what the patient is saying, the client is saying. And there's often a very natural question that would come next, but they're stuck in their own heads and they're going off in a different direction. So they're not really listening and doing the follow-up.
Okay. Patty, I want to thank you for this wonderful interview.
Thank you.